We are very honored to have him here. He helped us a lot with the hands-on workshop yesterday. So thank you very much, Dr. Atilla, and it's all yours.
Thanks, Asim and colleagues. It's a great pleasure for me to be in Pakistan, and it's a great honor for me to be in Pakistan. And I'm really happy to be here. So, uh, we have a Turkish Neurological Society, and under Turkish Neurological Society, we do have an interventional neurology society, and we are working hard for training people. We do have 25 certified interventional neurologists there, and 22 comprehensive stroke centers run by neurology team, and neurosurgery team is in the same program. So the training is important. By training, you can always improve your centers and be active. I'll talk about the tips and tricks of angiography. The time is not that much. So for ideal angiography, for cerebral angiography, we need to have a DSA, this digital subtraction mode for cardiologists. You do have to have roadmap. And flushing is important compared with coronary angiogram. We do use also heparinized flush to prevent thrombosis in the catheters. You can use a manual or automatic injection, but the air embolism is the major problem in several vessels, so we need to be very careful for the air to prevent air embolism. As we know, the anatomical and arcus aorta is, there are several types. Why is it important? Because of the microembolisms, regardless of what you are doing, in the, for example, carotid stenting, 15% of 10% of embolisms coming from the from aorta. And if the aorta is very ugly, we need to be extremely careful. And this kind of carotid tortuosity, it's maybe we can avoid digital subtraction angiography, and we go for non-invasive techniques, and this is important. And if it's type 1 aorta, it's easy to navigate. We select our diagnostic catheters according to that, and this is bovine arc, and we need to have a SIM2 catheter. With type 3 arc, it's important to navigate gentle maneuvers, and we need to know about the ostium, because if you don't know the ostium, there's always a chance of or risk of embolism to the brain. And we can do it with non-invasive imaging with CT angios, MR angios, or you can do a pigtail, as you are aware of as cardiologists, and see the ostium. These are the catheters. Type 1 is easy. A P-card, head-hunter, vertebral artery, or coronary Judkins can be available. Type 2, moderate. You can use all these catheters. And for difficult type 3, SIM2 or VTEC can be used. It depends on the products that you have in the country. Because, for example, in Turkey, the cook is extremely expensive. You cannot find VTEC or Valavan's catheter or P-card. But you can always find vertebral artery catheter, Berenstein or headhunter, and always SIM2 should be available for bovine arcs and difficult arcs. You need to use SIM2 for bovine arcs and know how to engage it. I'm not going into the details. And it's important to have sometimes CT and CT angios before acute stroke manipulations to see the aorta and plan your catheters and your strategy before stroke. It's always good to know. We need to always be very careful in manipulations, not go too far distal just to prevent dissections and the complications with the hydrophilic coated guide wires. Because when you go up in the upper segments, the clinoid segments, these are all in intracranial segments, and these are all lack of external lamina, and they are in the CSF. So we need to be very careful not to go for beyond the petrous segment with hydrophilic tail. Remember, with the aging, advanced age, there can be cervical loop, or sometimes in patients with fibromuscular dysplasia, we don't know if they have it or not before. They have a cervical loop, kinking, coiling, and these are the things that make the diagnostic angiography a little bit difficult and tricky, and we need to be aware of this kind of variations and be careful while passing our hydrophilic coated guide wire. Tips: be careful for cervical loop. We tend to use smaller diagnostic catheter, 5 French or even 4 French, to prevent embolism. Always use roadmap, and air embolism, be careful for that. For weaves, we need to use AP, lateral or oblique weaves, just to see the accurate anatomy with that. See that if you use only AP weaves, it's not enough, so you have to use lateral weaves for a diagnostic angiogram. And we need to be aware of all the arteries, as Dr. Rashid mentioned, in anterior circulation, MCA and ACA, and their lateral weaves. And we need to be aware of the collaterals, and we need to be aware of the penetrators. Look at the penetrators here, striates arteries coming from MCA. AP weave is necessary, lateral and oblique weaves is necessary, and we need to wait for the venous phase in cerebral angiography. I'll talk about it, and aware of collaterals and aware of variations, and look for all vessels in the acute stroke phase. Important. The collaterals are important. See, this is the patient with the left-sided MCA occlusion, and right-sided injection shows that there's a delayed phase of collateral from ACA, and there's a very nice collateral in the acute phase. It means that the patients may do well, and you have some time to open it. Here is another example of the left-sided occlusion of MCA, and the ACA is leptomeningeally, gives some collaterals to the MCA here. We need to take care about the late phase, not only the first phase, late phase, or venous phase, just to see the collaterals. Here's the lateral weave. There's a MCA occlusion here. If you wait for the venous or late arterial phase, you see the collaterals are coming from and feel the MCA from ACA. This is important. This is another PCA collateral to the MCA occlusion. If you give it from the vertebral artery, then you see the late collaterals and supplying the MCA. It's important for also for the complications. Be aware of this kind of carotid tandem occlusion. We go for an MCA occlusion. We did a stent removal with Trevo. ACA was opened before, but look, MCA is open now, and ACA is now occluded. So we need to be aware of all arteries, and we need to look at all arteries, not only focusing for the occlusion, because this is a complication. And lateral weave is always important after the procedures in acute stroke, because of to look at the distal arteries and occlusions in the distal arteries. So in the vertebral circulation, we have variations as usual in the carotid arteries, right vertebral, left vertebral. We need to be aware of the hypoplasia of the vertebral artery and be very careful while cannulating them. So these are the anatomy, and look at here. There is no right PCA here, posterior cerebral artery, but it's an anomaly. It's a fetal PCA, so we need to care about all circulation and their anatomical variations, because during the acute stroke you may need to adjust it and be aware of the anatomy. If you assess it as like a occlusion, you may go to the hypoplastic or aplastic artery. So these are tips and tricks. Last slides. Be careful for hypoplastic vertebral artery. Look for both vertebrals, because in the atherosclerotic disease it may be in the proximal right vertebral, or it may be in the left vertebral. It's a common atherosclerotic site for the proximal vertebral. Be careful for vasospasm. The vertebral arteries are very vulnerable to vasospasm. And gentle maneuvers, 4 French or 5 French Berenstein vertebral catheters may be useful, and look for anatomical variations. Thanks for your patience.